Right. Well, so I've done as best I can the welcome. We have one apology today from the Director of Nursing, Paul Moore, who is unfortunately unwell. We have the Declaration of Interests, which is part of the papers for the meeting. Does anybody have any additions they want to declare to those interests?
No, thank you.
No? Okay. In terms of matters arising, I believe that everything is covered within the minutes, within the agenda for today's meeting, so there are no separate matters arising that I've been notified of. Opportunity here now for anybody to say that they want to bring something up under any other business later on in the agenda. Does anybody wish to do that?
No, thank you.
No? Okay. So, John, would you like to just take us through the Corporate Risk Register and Board Assurance Framework update?
Yeah, my name's John Middleton. I'm the Board Secretary at Manx. The Corporate Risk Register and the Board Assurance Framework was brought to the previous public meeting. It's been discussed at the various committees of the board, and it's going to be sort of further refined at the audit committee, the next audit committee, which takes place in September. The intention being that there will be a organisational wide risk register, and the processes involved in there will form part of the board assurance framework for Manx Care, so that the individual committees can escalate concerns as necessary to the board, and we'll move towards a single unified risk register, which involves changing some practices in some care groups, which involves standardisation of a process, so that the process is being reviewed by the audit committee in September.
And for future meetings, the papers will include a written risk register and a written board assurance framework. So this is because it's the early days in our development, but from the next meeting onwards, you will have the papers that support that. Okay, I apologise. In my haste, I went past the minutes. Does anybody have any problems with the minutes or an accurate record of the last meeting? Okay, we can take them as being an accurate record. Fine. So we decided that we wanted to start our meetings by having a story of experience. So I'd like to welcome the team from neurology. We have Heidi Morris, occupational therapist Joe Roberts, and neurophysiotherapist Christine Wright. And between them, they're going to tell us a patient story.
So we've been asked to discuss our experience of working for Manx Care and share a story of one of our patients. So I'm Jo Robert, I'm an occupational therapist, and my colleague Christine Wright, who is a neurophysiotherapist, and we both work in community adult therapy, and Heidi Morris, who will be up in a moment, who is our neurology nurse. So we would like to introduce you to Mrs. X's story. She's a single mother. She's fiercely independent, and her main wish has always been to stay at home. Her kids are her highest priority, and she's got a child in secondary education. She's bedbound and requires a hoist for all of her transfers. She has 2 carers for 3 visits every day, which unfortunately is the maximum amount of visits she's allowed due to the costings. She's doubly incontinent and can be left in bed unattended for up to 14 hours overnight. Unfortunately, she's lost dexterity in her left hand and starting to lose it in her right hand. Her voice is also becoming weaker. She would benefit from electronic assistive technology, but there's currently no service on the Isle of Man for this at the moment, as it would give her some control back. She's struggling to feed herself and can only just about use her mobile phone. She's currently living in one room with no access to a bathroom, and she's unable to leave her property except under evacuation by emergency services. A platform ramp at the front of the property would allow this access in and out, and is currently going through the highest scheme, which is under the DOI, but so far it's taken 18 months, and we still have no technical support to manage the project, so it's still ongoing. There's a grant of £6,000 she can have on income support, but the rest is then charged to a property. But we've still got no one to kind of manage the project at the moment. So I'll just hand over to Christine.
Thank you. Good morning. So we've put together this timeline in order to show you how Mrs. X's story progressed and maybe highlight some points at which we feel that more resources and more time might have made a difference. So Mrs. X was referred to physiotherapy, and unfortunately due to our waiting list we had no capacity to see her for about 3 months. By the time we could see her, her transfers were already difficult and getting in and out of her house was difficult. So her attendance at outpatient appointments was sporadic, to say the best. She then deteriorated over a statutory holiday and had a commode delivered by an occupational therapy tech supporter. At that point she was unable to walk and her young daughter was transferring her to the commode. She was spending all day sitting in her armchair and all night sleeping in her armchair. At that point I requested the continence nurse to see her urgently, but she was also unable to see her due to capacity. She was unable to get inpatient rehab unless she was admitted to an acute hospital ward, which she didn't want to do because she hadn't got an acute medical problem. She had this sudden deterioration in her multiple sclerosis. And again, there was just no way we could increase the therapy input at home, not significantly enough to make a difference. So she was admitted to a nursing home, and although passive movements were taught to the staff there, they didn't have the time to carry them out, and at that point COVID intervened and we were unable to see her for 3 months. I mean, that was outside anyone's control. Before COVID she was still able to stand during therapy only and transfer with a lot of assistance. So it's my opinion that if we had been able to give more rehab at that point, it would have definitely made a difference. But she deteriorated to the condition she's in now really, which is bedbound, unable to sit out in a chair, unable to access bathroom facilities or even a toilet or bathing. I'm going to hand over to Heidi.
So we just wanted to also highlight some feedback from some of our patients following one of our educational self-management courses that we run. So generally patients do appear to be quite happy with the services that we provide when they can access them. I think a couple of the comments there say, yeah, particularly physiotherapy, it's great when they can get it. Someone else commented about Botox for spasticity, that's particularly for multiple sclerosis patients. They often have to go across to Liverpool for that, and that's something that perhaps we could provide over here. So generally people are happy with what we provide. And then really just to conclude, these are the key areas that we feel would really make a difference to our patients. So, you know, we want to be able to keep people at home for as long as they want to. And to do that, we need to be able to give them the therapy that they need. And we need the carers or relatives to be able to have access to respite, which at the moment planned respite isn't available on the island. We would like patients to be able to have access to medications that are available in England that wouldn't necessarily cost any more money over here, and in some instances may save money. We want to be able to work more closely together with other specialities. For example, shared care. We want to be able to work closer with the GPs. It would be nice to have clearer guidelines as to who's responsible for prescribing and monitoring medications sometimes. And effective technology and processes. as Joe's highlighted, sometimes there can be difficulties with the process to make adaptations to properties and things. I've also put a picture there of Joe's mobile phone. I'm fortunate I have a smartphone for work, so when I see patients in the community I can access my emails and things, but that isn't the same for all health professionals. So it would be nice if we could all access emails and we could access each other's clinical notes relating to patients. And that's it really, just some references just to back up what we've been saying. Thank you.
Thank you, Heidi. And just to clarify that although what you've told us is substantially accurate, a few details have been changed just to protect the patient's confidentiality, I believe. So that's just wanted to make that clear. So I guess before we pass over to anybody else to ask any questions, there's a resource issue here, isn't there? Basically, you feel that you need more resources to give a better service, and I think you've prepared a case for that, haven't you? Is that right?
Yes, obviously, you know, we do need more resources to provide the care that we'd like to, and keep people at home as long as they want to.
Incidentally, the microphone is just for recording the meeting. You'll know that there isn't a loudspeaker anywhere in the room, but it's so that this can be adequately broadcast. Okay, Teresa, did you want to comment on this? And just, by the way, just introduce yourself first of all.
Yes. Hi, thank you for the presentation. I'm Teresa Cope, Chief Executive. I mean, I think a lot of, and I know we've met before, and I know a lot of what you've spoken about really resonates. So I think there is the business case. There is a broader piece of transformation, and Sally will probably want to come in here as to how we get the social care support and that intervention in the community in order to maintain people's independence, because it does seem entirely inappropriate that you have to come into hospital in order to get the right package. And what I sort of picked up from the start of your presentation was that actually a sort of a slight uplift in the care package would probably make a huge amount of difference to this lady and her life, and ultimately maintain her independence. So I think there is a broader piece of work about how we develop the intermediate tier, and that is a programme of work we've got established. I think there is absolutely an opportunity to improve multidisciplinary working and to build a care planning approach involving all professionals, and Manx Care as an integrated care organisation should mean we can do that well without necessarily having all of the additional resource. We can just make sure we've got the right professionals involved in planning the care for this lady and join it up as much as possible. The NICE approved medication is something we're actively working upon. We know that previously NICE hasn't had the separate funding, but Manx Care is working really closely with the Department of Health and Social Care and the government, and we are making some progress in that space, and we're about to bring something to our Executive Management Committee internally which starts to describe our internal approach to working and delivering NICE approved medication. And I think, again, just coming back to the technology, that would make a huge difference again. And I think we need to look at opportunities within our digital plan as to how we can accelerate the amount of assisted technology we have available to our patients, which ultimately, again, support their independence. So thank you to the team for highlighting this. I actually think we can make progress in all of those 4 areas you've highlighted to us, and I think we should absolutely bring this back to the board in a few months' time to demonstrate the progress we've made in each one of those 4 areas.
Thank you. Thanks for having us and giving us the opportunity to highlight our experiences.
Sally, did you want to contribute?
Yeah, absolutely agree with everything that Teresa said. Having heard this
So
story...
just explain who you are.
Oh, sorry. I'm Sally Shaw. I'm the Executive Director for Social Care. And I heard this story at one of the previous committees, and I have actually said one of the actions from that committee was to look at this story bit by bit, to look at all of those. It's a whole system approach that's not working here. And I understand about additional resources, but we need to look at what we've already got and how we use that differently as well. I think, you know, there's lots of things that this raise around, you know, it fills me with absolute concern when we hear a maximum amount of care that we can provide that's service shaped. It's not person centred shaped, and this isn't your issue, this is a whole system issue. And how we use our care at home and our district nursing staff together to support. There's things around, you know, the delay in DOI and getting a ramp, that should be done, you know, quite quickly. And in other areas, there's schemes to enable that to happen very quickly, so we need to learn from those other areas. There's issues here that haven't been raised yet, but were raised at the last committee around young carers. You know, this person, you know, had children who also needed support in caring for their mum. And again, I'd also mentioned about assistive technology, Teresa. You know, we need to actually scale that up quite quickly in all areas of health and social care.
Thanks, Sally. Sri?
Yeah, sorry, Sri Ando, I'm the Executive Medical Director. So I think during that whole pandemic, a group of patients who needed more of physical therapy and occupational therapy, they've been disadvantaged in one form or other, and that's a general issue. There are lots of research that has come about that you can deliver some sort of remotely you can deliver the therapy that can help the patients when they go away from the hospital, and certainly in this case the patients who are actually already in at home. So I think it is about trying to kind of getting access to that kind of newer ways of delivering therapy. That would be about remotely delivering physiotherapy and occupational therapy. That would help in patients like this. While we are actually, we have got hybrid team which delivers the early support discharge support, but actually we have got more of a hybrid teams that work across different clinical pathways and different clinical conditions that can deliver this care. So all in all, I think over the coming months and years, we will have more of this technology that will be available for the patients to actually use it, because it is physically not possible because of the distances and geography. It's going to be a challenging aspect of delivering that kind of care.
Thank you, Sri. Anybody else? Katie and then Andy.
Thank you. So, thank you for the presentation. Can you tell me, and in fact, Teresa and Sally both referenced the whole care issue. In the specific instance that you're talking about, was there one person who was responsible for managing all of the partners associated with the care of this individual? Or did you come together as a team and always have a whole team approach? So I'm trying to get to the stage was one person managing the whole journey, or was it a little bit sort of somebody did this bit and somebody did that bit?
Okay. So I would say that the initial point of contact was therapy, so that was physiotherapy and occupational therapy. And the social work help came in as soon as we realised that was appropriate, and we did meet jointly. We had meetings at the patient's house where we discussed jointly with the patient how it was going to progress and what the options were at each point. And we have had case meetings when we can put them together since then.
Okay, fabulous. So to follow up, if I may, Chair, overall the responsibility for this
There's not a single key worker point. No.
Right, and that's what I'm trying to get to. So, right, okay, thank you.
Yeah.
Because it's from an integrated care perspective, that would be quite a good thing, wouldn't it?
Yes. Well, she's got a long-term conditions coordinator now, this lady. And so that was a really great post when it was brought into existence.
Fantastic.
I think they also have quite large caseloads, is that fair to say?
Okay.
But they're really valuable in patients like this.
Thank you. And Katie, by the way, is a non-executive director.
I beg your pardon, I didn't introduce myself here.
Randy Guy, I'm one of the non-executive directors. Heidi, I too was at the meeting previously where this particular case was raised, and it's a good example of small groups of patients with deteriorating long-term conditions. So just just to say, I've asked for this to be raised and discussed by the board in a private session, obviously because it's confidentiality issues involved as well. And from my point of view, it clearly demonstrates that historically there's been quite a lack of joined up work between departments, and that can't continue. Now, Manx Care have been required to use those shared services still, but we're asking and setting up service level agreements with all of those groups. It's fairly clear to me that the one with DOI, for instance, isn't working, and I think that's something that we probably need to escalate and raise again and figure out how on earth we get that sorted. Because obviously a delay like this if it was something simple to do with a piece of infrastructure in, say, a small crack in a bridge, that might be, maybe it could wait 18 months, but a patient can't wait that long, and that's just not tenable. And when I heard this story, I was very badly affected by it. I think we need to do something, and we certainly shall, I think, analyse it and try to come up with a sensible philosophy and way forward. So thank you very much.
Thanks,
for
Andy.
bringing it to our
Sorry, are
attention.
you responding to Andy's point?
Walter Kate has actually just triggered a thought that we have the wellbeing partnerships that are developing, and we're rolling that out over the next 12 to 18 months, and those partnerships will be able to support that complex need within our communities.
Right, so we better coordinate.
Yes.
Okay. Vanessa?
Yeah, I'm Vanessa Walker, also one of the non-executive directors and chair the Quality, Safety and Engagement Committee. And indeed, we did hear about this story. But one of the things I'd like to sort of share with other people is that, and thank you, Heidi, and the team as well, and for coming to the Quality Committee as well. But you did share also with us some of the frustrations that you experienced as staff members when you've got patients in front of you and you want to give your very best care. And I think that we as the Manx Care Board have a responsibility as well to the staff as well, who are, you go home every night and I can sense, you can sometimes feel that you might burst into tears at the frustration that you might have in terms of trying to find the resources and look after the patients such as the one you've talked about here. So I think that's something that's really worth us thinking about. But also, you've told us about one patient. Generally speaking, it's often illustrative of a number of other people who may well be in similar sets of circumstances. So I think when we're looking at this in a whole integrated sense, we're not just looking at it from integrating the care for this patient, but we're looking at a wider picture of integration so that everybody who is in any similar type of position as this lady starts his or her journey from an absolute integrated position where it feels seamless and they don't feel as if they're being pushed from pillar to post or haven't got the resources or this, can't do this because that doesn't happen and we don't do it like that around here. So I think those are the things, just in trying to be really constructive. I think it's just like trying to highlight those issues that we need to look at, and Manx Care's it's in the best position with the opportunity to achieve that, given that we're on an island and we can make that happen. And I'm starting to feel confidence already with what I've heard from the exec board members that that's starting to happen, and improvements for this lady have even started to happen. So it's just, we need to keep seeking assurance and pushing and pressing. But thank you so much for telling us.
Right, okay. Andy, and then Richard, and then we'll summarise.
Thank you. This is actually just if you like, a reply and response to Sally's point about integrated care. And I agree, integrated care should make a difference, particularly, because you've got, as you say, you've got wellbeing centres where you can coordinate that care. However, I think that those pathways don't probably exist yet, and they're largely untested. And I think what we have here potentially is a group of patients that need probably a more immediate look. So I suspect we may well have to jump out, analyse that particular pathway and actually use it as a test case, if you like, for full integration, even though that might not exist, but it might give us a model to actually work to.
Absolutely.
Richard?
Thanks, Andrew. Hi, I'm Richard Wilde, and I'm the Chief Information Officer, the IT guy at Manx Care. And thank you very much for that story. I think it is very powerful. And you spoke about not being able to see other notes from different care groups, and I think this story really does illustrate the importance of us doing that. You know, we know that the 7th Caldecott principle is the duty to share, and the way that the system is currently configured, it makes it very hard for you to be able to fulfil that duty. So we know that principle tells us that registered and regulated health or social care professionals need to be able to share information about the care of a patient with whom they have a legitimate relationship. And that's absolutely the goal of the Manx Care record, is to give us that pathway view of a patient's or a service user's journey through the system. But that is some time out before we implement that new system. It's going to be a very big piece of work, and I think it will be truly transformational. And just to emphasise Teresa's point, I think that we need to meet in the short term and think what things can we do in order to be able to facilitate that sharing and around the assistive technologies as well. So thank you very much. I think it really does illustrate those points.
Thank you, Richard. Is there anything you want to come back with, either of you?
Could I say one thing to finish? And I totally agree with everything you say about pathways and better procedures and administration. However, there is one more thing that we're missing, and that is actually the working hours in therapy on the ground to actually physically treat patients. And me and my colleagues in neurophysio, there is just about over one whole-time equivalent to treat 170 MS patients, over 200 Parkinson's patients, and everybody else with a chronic neurological condition. And so it never stretches far enough, unfortunately.
And it's exactly the same.
And OT is exactly the same. Yeah.
Okay, well, thank you very much. I mean, we've heard a story of a service which isn't good enough for the patients, that's frustrating for the staff, and there are issues of resource, technology, and coordination. You're putting together, or you have put together, a business case for improvement to that service, which will be considered by the executive team, and we'll have a report back on this to a board in a few months' time. So thank you very much for coming along and telling us not a very happy story, but good to have it brought to our attention. Thank you.
Thank you very much.
Thank you.
Thank you. Right. The next item on the agenda is my report, and I've only got 2 items on it, both of which we've sort of covered already. That one relates to the difficulties of coronavirus, and I've talked about the arrangements we have to try and manage a public board meeting today as best we can. The other thing is that some of us are based off island. I'm based off island, and even though I was appointed to this position in September last year, it was only earlier on this month that I managed to make my first trip here. But it was, I wanted to record what a pleasure that first trip was. I'm sure the sun always shines on the Isle of Man. It certainly did last time, and it has done so far this time as well. But also how impressed I was with the place, the people, and the facilities. I've worked in many hospitals over the years, and this is a lovely hospital. It's beautifully designed, it's very attractive. It has its deficits, of course, but I was very pleased with an awful lot of what I saw on my first visit. So that's the end of my report, but let's move on to Teresa.
Thank you very much, Chair. So I'll largely take my report as read. It is a summary of all of the activities that I've been conducting during the course of late June and July, and is supplemented by an horizon scan, which just details the actions that are going on within each of the operational care groups, plus a summary of my visits and meetings with service teams over the course of the month. Visibility is really, really important. It's important to me. It's also important to the wider exec. So all of the executives have been visible, out meeting teams and supporting as much as possible. To supplement the paper, what I would just like to do is just give a update on where we are with COVID. It is rapidly moving, and the numbers of cases in the community have increased significantly during the course of July, to a point where we have now put in some additional restrictions across health and care services. in order to minimise the risk of infection spreading across hospital and care services. So as of the 19th of July, we did implement some visitor restrictions across some of our services, and we have stood up our command structure arrangements. So Bronze Command is meeting 3 times a week and feeding into the Silver and Gold Command meetings. Obviously, the vaccine programme has been incredibly successful. So unlike other outbreaks, we are not seeing that translate through to high numbers of admissions at the moment, which I think is very positive. But as of today, we currently have 7 admissions into hospital with COVID-19, of which we have 1 patient being treated on critical care. As I say, I think our staff have responded exceptionally well. I think it is important to note that in terms of community transmission, we are at over 2,000 cases due to this particular episode of the pandemic, which actually exceeds the numbers of community cases that were present in the previous 3 outbreaks going back to last March. And I think that puts it into context, but it also does signal how effective the vaccination programme has been. The only other item of my report that I just wanted to draw everybody's attention to is the commencement of the Manx Care Advice and Liaison service, which goes live from next week. This is a confidential telephone and email service which is accessible to patients, service users, carers and their families, and does mirror the PAL service, which a lot of you will be familiar with the UK. This was really important as part of our communication and engagement strategy and our interface work with patients and service users. So this was very important to Manx Care that we got this service up and running. So it will start from the 2nd of August. It will operate between the hours of 10 and 3, initially Monday to Friday. We will evaluate the effectiveness of this service and then start to build out from that. The executives are currently in the process of signing off the standard operating policy for how that service will operate. So I think that's the only key things I wanted to pull out from my report, Chair, but I'm happy to take questions on my report.
Okay, Andy and Vanessa. Andy first.
Thanks, Teresa. The one thing that from your report is, one particular thing, is the approval of the extra money for catch-up. So that's operations investigations which have been delayed by the pandemic. Are we confident that we're going to complete all of that before the end of the financial year, or do we need to manage DHSC's and the government's expectation that effectively some of that will continue over into the following financial year? Because obviously, discrete funding periods, etc., just to make sure that there's no confusion and therefore, and we don't end up with an issue later.
Yeah. I think when we wrote the business case, and I might ask the Director of Operations to also comment, but when we wrote the business case, the expectation was we would spend all of the money in this financial year, and we had a clear delivery programme. Now, obviously, that was all heavily caveated by COVID, which will have an impact on our ability to deliver. Certain elements of the programme are quite fixed and do not rely on hospital-based capacity, so the opportunity to work with Medifer and 18-week support and do some of that virtual consultation work should be unaffected. But I think it's a case of keeping a very close eye on the delivery of this piece of work. We've already committed to bring a monthly update as part of the integrated performance report to the board, and at that point we will also track the financial expenditure, because I do think if we are going to need to move some of that programme into next year, it is quite right that we signal that to the DHSE and colleagues and Treasury as soon as possible, but probably a little bit too early to say.
Thank you very much.
Oliver, do you want to add to that?
So I'm Oliver Radford, I'm the Director of Operations. So I'm having weekly meetings with our suppliers, Medifer and 18-week support, and they're still confident that we'll be able to deliver by the 31st of March. We're looking at increasing our capacity within the cataract services. So we're purchasing about 1,250 cataract operations from 18-week support, and that they'll be delivered here on Ireland. We will be using spare capacity within our theatres, but what we're looking to do is to actually free up a theatre on a Friday so they can work Friday, Saturday and Sunday, which will mean that their whole programme can be curtailed. From an endoscopy point of view, we have 3 endoscopy rooms that are empty at the weekend, so that's more than enough room to for them to undertake the 1,250 endoscopy procedures that we've commissioned through 18-week support. So I don't see any issue around delivery, but clearly as you know, COVID is you know, on the rise both here and the UK, there might be issues around availability of staff because they might be identified as close contacts in the UK, or they might catch COVID themselves, but we're managing that on a week-by-week basis, so I don't see any problem.
Thank you, Oliver. Okay, Vanessa.
Yes, two things, please. On page 1, Teresa, you've referred to the Palliative Care End-of-Life Oversight Group. I wonder if at a later date, Quality, Safety and Engagement Committee might have a bit more detail on what that's achieving. And what I'd particularly like to know is our approach to end-of-life that isn't just about cancer end-of-life, and whether or not people who are in hospital or in any other care setting, it's whether or not it's being recognised by staff that they may be approaching end of life, and that they have all of the same support and help, and you know, in terms of approaching end of life. So that's what I'd be really interested to learn a bit more about. So I don't know if working with John that could be put onto an agenda item at some stage in the future. So then the other thing is at 2.8 with the Manx Advice Liaison Service. How well will people know that that exists, and are there to be any hubs in the, say for example in the hospital or any other places, so it's clearly advertised that people know where to go?
Yeah, and we are just about, in fact today I shall be signing off all of the press and the comms and all of the brochures which will support this service. As I say, at the moment it's quite a small discreet service, and it's based in the hospital and has its own unique email address and phone number. But I do think as we broaden this out, there is an opportunity to strengthen its relationship with the geographical hubs across the island, and to connect it into some of the hub working and some of the voluntary and community sector work that we are joining onto. So to get a little bit more integrated, but I think we just want to see, we've obviously set up the Manx Care Inquiries line when Manx Care was established, and actually we do get quite high volumes through that every day. And what we want to be able to do is ensure that the public have the opportunity to contact us directly and get their queries dealt with promptly and by the right people, and that we sort of take a responsibility for responding in a timely way, but also helping the patient, the service user or their family navigate our system and join the dots. And I think that's where we see this evolving. So definitely there's scope and plans to get it stronger integrated with the geographical hubs, and to build out from that model once we make sure it's actually right-sized and working okay.
Thank you.
Thanks, Vanessa. And I'm sure in relation to your first question about having a presentation from the Palliative Care Group to Quality and Safety and Engagement Committee, I'm sure we can manage that, can't we? So take that down as an action. Good. Katie.
Thanks, Teresa, for adding a little bit more detail to the COVID situation. I wonder, please, could you comment on the use of masks in the community, and whether we have advised the government that that should be something they should be advising, or whether we have taken a step back from that sort of discussion? Do we engage in that sort of advisory behaviour?
Yes, we do. So we have the opportunity, we sit on what is called the Clinical Working Group, which meets weekly. That's the silver group, and that discusses a wide range of matters of sort of clinical significance around use of masks, the approach to using lateral flow testing, the whole testing strategy. And I think, you know, that group's been incredibly active as we've moved from a elimination strategy on island to a living with COVID and mitigation strategy. So it has been a huge change and a huge shift. And obviously I think it's fair to say there is a level of anxiety about the level of community transmission. And what I've been keen to stress through those groups and feed up into Gold is that even though health and care settings may take stronger actions in order to reduce the opportunity of spread by increased use of social distancing, by use of masks, by restricting visitors, that is our version of living with COVID, and it's really important we protect our vulnerable patients and service users. So in summary, yes, we absolutely have the opportunity to influence and shape the government agenda. We certainly can't change the government agenda, and I think we're hearing very clear messages that this is about living with COVID now. We are in a session tomorrow because there has been an outbreak plan published, and we've contributed to that. And the session tomorrow is to look at what's happened over the last 3 weeks and whether that outbreak plan is still holding true. And I think from Manx Care's perspective, we've put all the plans in place around how we would use our beds differently, how we would create white and red areas for COVID positive and COVID negative patients. The biggest factor which will influence our response is staff absence. So we're now starting to see quite a lot of staff being directly affected with COVID and staff also having to self-isolate. So whilst we've got incredibly good plans about how we would configure this state and respond, ultimately our levels of staff absence will drive our business continuity arrangements and ultimately mean that whilst we may show we've got very low numbers of admissions to hospital with COVID, actually the ability to maintain all of our services at their standard levels is compromised, and we will need to move into a level of business continuity. But that is understood by the government.
Okay, right, I think we're going to move on to the next item. Thank you, Teresa. Just for the benefit of members of the public, we have, I think, 7 committees of the board which look at matters in greater detail, having to devote more time to them. And the routine that we have is that each board meeting will have a summary from any of those committees that have met in the past month, and we've got 4 of those here. Now, as part of the board papers, you've got a written summary report from each of those committees, but just invite the chairs to give any highlights or points of emphasis that they want to from the latest meeting. So, Vanessa, would you mind going first with Quality, Safety and Engagement?
Yes, of course. Thank you, Chair. The Quality, Safety and Engagement Committee is the first one that falls in the cycle of committees. So I'd like to think that at our last meeting we established maybe a new theme for some of the other committees in terms of governance and administration and receiving our board papers in a bit more of a timely manner, because I think that it's really important that we as the non-exec team have sufficient time to read through enough of the detail of the reports to be able to ask the right questions of our exec board members. So, and I think that's flowed through to the other committees. We also heard the same story that we've heard this morning, and so we've made some quite good comments on that. I think later in this meeting we'll be talking about the Integrated Performance Dashboard anyway, which is a developing and emerging documents that we receive on a regular basis. And I think with the best will in the world, we'd say that it's still got some distance to go to become a really live working document where some of the so what questions are asked. So I think that's the main thrust of it. We're starting to receive plenty of information, but not necessarily always in intelligence that we can ask and what's the outcome and what happened here and what must happen here and what the next action point. So that was something else. And one of the things I did want to highlight is we received a very well written paper on criminal exploitation of children and vulnerable adults, which we've also brought to, wanted to escalate to this board. And I think that with the best one in the world, there's maybe, I'm myself included, would have a degree of naivety about the actual extent of what can and potentially is happening on the island. We maybe think, oh, this is, we're a bit protected and a bit sleepy and a bit back, these things aren't impacting, and they very definitely are. So I was really very, very grateful that this report came to that committee, and that Sally and others and her team and the wider partners are actually working on that. So it was a really interesting meeting. The other thing that I would just like to sort of finish the comment on is a bit of a reflection and the feel of how the committees are working. Certainly, my sense of it is that we will say, well, what about this, and we need this to happen. We'll be a bit pushy sometimes and a bit challenging, but my sense of it is we're knocking at a door that's absolutely wide open, and I absolutely want to congratulate and applaud our new executive team members for just being so candid and open and transparent and willing to respond to what we're saying, and that as every committee meeting goes by and every board meeting goes by, we can tangibly feel as if there's improvements being made. So that's my summary, Chair. Thank you very much.
Thank you, Vanessa. Well, there's a challenge to the other chairs to match that. So People Committee next, Sarah.
No pressure, Chair, no pressure. I'm Sarah Pinch, I'm the Vice Chair of Manx Care, and I chair the People Committee. We were, as Vanessa has said, very keen to hear in the quality meeting from patients, and similarly in the People Committee from our staff. And one of the things I was very proud about in this meeting is we actually had a member of staff come to the committee to tell their story of setting up and being involved with the Vaccination Hub. And it was a very powerful story of cross-working across many areas of Manx Care, but also of government and other departments. And I'm really pleased to see the number of vaccinations that have been delivered and the number of adults in the population who've been double vaccinated. That establishment of that hub was not without challenge, but it was very much a story of cross-working, and it was a real pleasure to hear that. I must congratulate colleagues led by our Director of HR and the development of our People Dashboard. It's a constant theme across the board of access to data. We know the data is out there somewhere. We're finding it, and certainly for the People Committee, we are really seeing that coming together. So thank you, Anne, for you and your team's work on that. And then the only other thing I wanted to highlight, Chair, was the Team of the Month and the vital importance of saying thank you to our staff. And I think that is something that we cannot and should not ever underestimate. And it doesn't need to be a big event, although we do hope that we will move towards having a staff awards ceremony and everything that is contained within that to celebrate staff who go the extra mile, who do additional work, but actually starting with a Team of the Month. And Andrew and I indeed had a follow-up meeting about that yesterday, and I'm very encouraged by the speed at which that is happening, because I think we have gone through a very difficult time as a population through COVID, and indeed our staff in health and social care have been very much on the front line of that, and so it's really important that we get that into a place, and Andrew and I know that presentation will be coming to the Executive Committee for sign-off, and then back to the People Committee and back to the board. So that's all I'd like to say. But that isn't all I want to say. I've got one final point, which is to echo Vanessa's, which is it is a pleasure to sit on this committee and to chair it. And that is not something that I always say about other boards that I sit on and other committees that I chair, but the openness and the conversational nature of the meetings is not without challenge, not without pushback, not without difficult conversations, but they're held very much with a huge amount of respect and support.
Thank you, Sarah. Excellent. And now we have the Heavy Weight Lifting Committee, the Finance, performance and commissioning. So over to Nigel.
Thank you, Chair. So no pressure then, no pressure. So for those of you who don't know me, my name is Nigel Wood. I'm a non-executive director and I chair the Finance Performance Commissioning Committee. You will have some papers and some notes in the pack, I hope, and had a chance to reach those. But I would also like to echo Vanessa and Sarah's points in that healthcare is a new sector for me. I've been in business most of my life, and I've been absolutely delighted at the openness and the transparency and the way in which people are communicating at finance. I mean, money is important. It's one crude way in which we reward ourselves and measure ourselves, and clearly it's partly at the heart of Sir Jonathan Michael's report. But the challenges here are all about, I think, identifying the tensions, identifying the challenges, and switching resource from one area to another, saving money, making gains that we can make in our system and applying those gains faster and quicker to areas of need and areas where we really need to be spending money. So a very challenging and interesting committee. We run a very open book. We meet monthly, and although next month's meeting will be devoted to the full board because we'll be looking at budgeting. So although we're only 3 months into Manx Care, we're already looking at our budget for next year and going through the processes to apply to Treasury and the DHSC for those matters. We're also introducing new concepts within the Finance and Performance Committee, such as the difference between a budget, the difference between a projection, and the difference between budget projections and I've lost the word, sorry, I'm thinking too fast. Budgets, projections, and
Performance?
Sorry?
Performance?
Performance. Thank you very much indeed. Sorry. So very pleased about the way in which that is being presented. Improvements to the management accounts. Huge work by the finance team at a time of great pressure with COVID. They have day jobs too. I think just to sort of draw out one or two other items, I had a conversation this week with the lead manager of the CIP program, Cost Improvement Program in Liverpool, to make contact on behalf of the board with a major service provider. And I felt that was very useful indeed. And I think Keith Barton, felt that to have direct contact from the board was very useful. And we had an open conversation about how we could support the executive more and how we could support the board more in this evolving process. So very pleased about that. Other aspects that I'd like to mention is that clearly I echo your thoughts, Vanessa and Sarah, about the IPR, the performance statistics, in that is evolving, and I think it's evolving very well. And obviously, Jackie, you'll address management accounts in the pack as we get to it, but that is improving drastically from where we started. And I think the other item I'd just like to raise is that we also would wish to consider renewable energy and sustainability. We have a statutory duty to do it, and I think that's something that we would like to get on the agenda of the main board. But overall, Midway report, doing well, performing well. The committee meetings are fun, they're challenging, they're purposeful, and it provides an opportunity whereby executives and non-executives can interact. And I think probably, although we are a unitary board and the non-executives are setting the governance environment in which the executives work, the subcommittees provide an opportunity for a distillation and an exchange of views and an exchange and use of experience of the non-execs, which sort of could be said to be crossing the line, but doesn't. And we're very aware of that, and I think it's working very well. So thank you, Andrew. That's my report.
Thank you, Nigel. And then the final one from this month is the Mental Health Act Legislation Committee. Ali.
Thank you, Chair. This is the first time this committee has met in this month, and there is quite a sizable set of tasks here. But there are three themes that the committee addresses. The first is compliance with the existing Mental Act as it stands, including all of the protections for individuals, which it's not entirely clear at this point whether all of these things are handled perfectly, but we've got a dedicated team of individuals who are, to a degree, hampered by some quite outdated legislation I'd probably go so far as to say it may well not be fit for purpose. The second part is that it really needs to develop some policies around some of those compliance issues, and finally that it really does need to take a role in shaping the argument about updating the legislation. In detailed terms, one of the principal things that was discussed was section 115, which is aftercare after someone has been deprived of their liberty for a period of time. And that is a very complicated area and a very expensive area. And there is no true policy as to how those expenses should be contained, managed, and there's no clarity for individuals about what should and shouldn't be available under that, which we will be addressing over the next few weeks. So we'll be bringing that back and trying to give the board a higher level of assurance than we've been able to give so far. Thank you.
Okay, well, thanks to all the committee chairs. Does anybody want to question any of that at all?
If that's all right, I'm just going to add something to the Mental Health Legislative Act meeting itself. On the island, we do not have a Mental Capacity Act. And enabling an act that actually mirrors the Mental Capacity Act is a bigger piece of work that is done by the...
Do you want to just outline what the Mental Capacity Act does?
So, Mental Capacity Act is in its true form will actually act as a voice for the patient and be able to treat patients who do not have the capacity to make decisions for themselves, right, either on their medical matters or on financial matters. The idea of having an act on the island would actually try and capture all those elements, and that is not exclusively for the Manx care to implement. No. We have to work with the other bodies within the Island of Man, which includes DHSE and others. So while we are enabling our own sections within the Act, there's a bigger piece of work that is evolving as well. So there's lots of joined up work that we need to actually manage this one. Yeah.
Thank you, sir.
Thank you. Okay, right. Well, we'll move on now. Now, just again for the benefit of the public, the Manx Care was established on the 1st of April, and every year it's given a mandate, and a mandate is what it is expected to achieve in the year in question. So the purpose of the next report is a Q1 update on how we're doing against the requirements of the mandate. So over to you, Teresa.
Thank you, Chair. So as well as the mandate, Manx Care also published a required outcomes framework which set its priorities and which largely mirrored the mandate requirements. And to supplement this document, we also felt it was pertinent to revisit the recommendations of the West Midlands Quality Review, which took place about 2.5, if not 3 years ago, because actually they did make some incredibly relevant recommendations. So this document here provides an update at the end of Q1 as to the progress we have made against those 3 elements: the mandate key lines of enquiry, the required outcomes framework, and the recommendations made in the West Midlands Quality Review. As I say, it is an iterative document. It will be brought to the board each quarter. And what I'm looking for today is the board to approve this document for it to be submitted for discussion with the Department of Health and Social Care at the Mandate Assurance meeting on the 11th of August. So the updates are provided. I would just pull out a couple where some progress has stalled. So the wider transformation programme, which is led by the Cabinet Office and responds to all of the 26 recommendations of the Sir Jonathan Michaels report, some of those pieces of work are being led by the transformation programme. So if I could just take you to the improving patient safety section. Unfortunately the page is, I think it's page 12. The work that we need to do on ensuring that Manx Care has all appropriate policies and procedures, that's section 1.2. and also the review of all tumour sites, which is 1.6, and also the access policy 1.8. These are all pieces of work that are being led in conjunction with the wider transformation programme. We are, or Cabinet Office are in the process of moving over to KPMG as the new transformation partner. So there has been a little bit of slippage, around 6 weeks, as we've moved from the previous team of consultants supporting that piece of work to the new KPMG, who are just taking up that programme and now starting to work with Manx Care. But I think on the whole, we've done a significant amount of work during the quarter. I'm personally very pleased to see the theatre improvement programme progressing well, and I referenced that in my Chief Executive report. I know the previous Director of Nursing and the Medical Director have done a huge amount on improving the serious incident management framework and investigation policy, and making sure that we are a learning organisation. So we are learning from incidents, and we are making sure, as far as possible, those incidents do not reoccur. I think, as the Vice Chair has alluded to, again, we are making a lot of good progress around our priority of creating a positive working culture, working with the workforce and culture teams, setting that delivery framework. We have a very highly visible executive team who are doing a lot of staff engagement, a lot of listening events, and we're starting to put that in action. And as we've heard from Nigel, we now do have a cost improvement programme in place. Our CIP programmes are going through impact assessments. There's been a huge amount of work to work through historic business cases, identify which are the priorities from a Manx Care perspective, and agree the funding streams for those. So certainly around the improving financial health, the business case review group has been meeting weekly during the quarter to do that huge amount of work to give us a very, very clear baseline from which we manage the rest of the financial year. So I'm happy to field any questions on the report. It is work in progress, but I would suggest I would be asking the board to approve this at the end of Q1, noting that there will be a further iteration coming at the end of Q2.
Okay, thanks, Teresa. Any comments or questions? Katie?
Thank you. There's some really great stuff in here, Teresa, and I commend you for it. It's really great to see some of the progress, and I'm happy to support the report going forward. I would just make a point, though, on Q004, there's a blank cell against the response, and I'm sure you've got a response, but if it's going to the department, we just need to make sure the response is in there. So I just want to make that note, but other than that, I'm very supportive, so thank you.
Thanks, Katie. Jackie?
Thank you. I'm Jackie Lawrence, I'm the Executive Finance Director. Just a minor point similar to Katie's is that when you look at the F responses, they refer to appendices which are not included in this report, which actually contain the detail of the answer. So we just need to make sure that they're incorporated.
Yeah.
Thank you.
Okay, thank you. Vanessa?
Yeah, just forgive me if this comes later in our agenda, but I just don't want to lose sight of it. Where you start to talk about the serious incidents, never events, and that sort of thing. And maybe it is a question for later, but I'd really like to have some assurance at some stage on who investigates these things, how well trained they are, how robust the investigations are, whether or not the training of being investigators is shared so that you can get sort of that cross-fertilisation of other departments, you know, being included in a sort of critical friend kind of way involved in those investigations. So apologise, that's a bit of a vague question, but I think because I need to know more, I need to have more clarity for assurance on how they're investigated at some stage. And if you've got anything to answer now, well, I'd be pleased to say that. to hear that as well.
I think the operational policy which sits around the incident management policy does cover all of that, and I think you're absolutely right. We need to be assuring ourselves and the board and its committees and indeed the patients and families that we do operate with a degree of independence, that our investigators are all trained to a good standard, and that most importantly we are learning. So I'm confident that is all within the policy framework, which is going to the Quality and Safety Committee for final sign off, I think, in this month. Yeah, so I think you should see that, Vanessa.
Thank you.
Yeah. Can I just add to what Teresa said there as well? I think there are, you asked several questions, but one question within that is about the time frames that you need to be adhering to. I think that may be something that we need to be getting better at, but generally speaking about the training of the investigators, are they actually qualified to investigate something? Are we actually seeking approval as an assurance? There's no such thing as, is this the best? You know, we're working on it all the time and we're trying to reinvent ourselves to see that, but it's always under review as we go along. Yes, the framework itself, incident framework, it keeps asking you those questions on a regular basis. And we work with a team, which is the patient safety team, which you're aware of, and that would be going through those kind of teams of members, not individually as that.
Thanks, Shane. Thank you.
Andy?
It's not a question as such, Teresa. I'm happy to support the report. I think it has got details an awful lot, which is great. But it's actually under the key lines of inquiry from our colleagues in DHSC. I feel that question 008, which is describe how the recommendations of previous existing commissioned external reviews are collated and monitored, is a little disingenuous, considering that actually that should already have been given to us as a part of the history, which it wasn't, which is why there are so many WQRMRS recommendations outstanding. So it's just a commentary that I think actually it's a little bit unbalanced from the other side, and that's from an outside view as a non-exec.
Yeah, this was one of the points of Sir Jonathan Michael's report, that there had been many previous reports and investigations whose recommendations had not been implemented.
Yes.
And this is what we are set up to make a change to.
So there's a huge catch-up to
do. Yeah. One comment I've made, Teresa, is that, as you said, we will have an assurance meeting with the Department of Health in August, and they'll be wanting to measure how we're doing against the mandate. And I'm wondering whether we could provide a self-assessment, possibly in the form of a RAG rating. We do it on the ROF, but not on these the Chloes here. But just at a glance, whether we feel that we are on track, somewhat behind track, or serious problems.
Yeah, no, I think that's a good idea, and I'm happy to include that.
Yep.
I also feel, possibly responding to the point Andy has just made, but also to sort of describe, I guess, in a little bit more detail, a covering letter which identifies, building on the baseline we presented just before we went live, and perhaps some additional learning and updating of that baseline that we've found subsequently during Q1. I think that is probably quite important we articulate that, and sort of offer up and be really transparent about where we maybe haven't made as much progress as what we would have hoped.
And of course the last part of this paper is a report on the West Midlands Quality Review Service, so recommendation by recommendation, so it is doing that.
Yes.
I'm sorry, Chair, I just got a couple more just stickers in here that I just didn't see to start with. One is just at 2.22. Is that something still to cover, Teresa, or still within this report? But we got. Yeah. It's just the Clatterbridge Nobles model of delivery. Yeah. And so again, I'd be interested to know, and I'm sort of thinking about this culturally and contractually, what's the vision for that, and how committed can we absolutely be assured that Clatterbridge clinicians are? And I suppose what scares me is that because they're Clatterbridges and they're not here, that we get a bit poor relation treatment, and I don't want that to happen.
No, no. And that piece of work is going incredibly well. The clinical teams, operational teams, are meeting weekly with Clatterbridge. We have that very well defined within the contractual position with Clatterbridge, with a very clear commitment to absolutely ensure that the quality of provision, the clinical pathways, the standard operating procedures that in use in Clatterbridge will transfer across and be used in Noble. So it will be a mirrored service where we will be able to give the assurance to Isle of Man residents that they are receiving exactly the same standard of care here as what they would if they had been treated at the Clatterbridge. So our clinicians are linked into the governance systems around clinical support, using the same standard operating procedures. So I think this is a particularly area of really, really good progress under Manx Care in the last few months, and a very strong model for future delivery. So I could see us doing a Spire at Nobles or Liverpool Heart and Chest at Nobles, because actually that is part of our strategic partnership model, to be able to replicate and use the clinical networks from the Northwest in order to make sure we are delivering clinically and financially sustainable services on island. So I think this is a particular, and we're talking about it tomorrow on our Let's Connect session. I think this is a particularly good piece of work that's made a huge amount of progress in the last 3 months.
I applaud it in principle. I just want to know that it's going to work. And I've got one final thing, I'm so sorry, in this paper, and it does relate to the West Midlands Quality Review Service. And on the first page, I just read the sentence, does not align to the recommendation recognised by Manx Care. So I just want to ask the question, be assured that we're not signing up to something that's prescribed to us rather than tailored to meet our needs.
Yeah, so I think there is obviously the West Midlands Quality Review was at a point in time, and whilst I think it is important we go back over those previous reports and understand the relevance of them now and where we stand against those recommendations, I think if things have very clearly moved on and those recommendations are no longer relevant to us, there is that sensitivity there to contextualise them, and for Manx Care to agree which ones should absolutely be progressed and perhaps the ones which are no longer relevant or have been superseded.
Thank you.
Right. So I think the board has accepted and approved that update. So thank you for that, Teresa. We've now reached the point where we are due to have a refreshment break. Slightly early, but can I suggest that we do that now and come back just after 20 past? And just to remind you that if you're going to walk around the building, please do put the mask back on. For the benefit of members of the public, one of the first things that Manx Care was to decide what its 3 initial priorities were. And you can see from the way the agenda is structured, improving patient safety, creating a positive working culture, and improving financial health. Those are our top 3 priorities for this year, and that's how the board meeting is constructed. So we'll, I beg your pardon, I've skipped past the integrated performance report first. Do you want to just give us any headlines from that, Oliver?
I just wanted to, I won't go through the report in detail, but I'll just highlight a few areas where we are addressing areas of poor performance. We've mentioned earlier around our successful business case that we have achieved Treasury funding to increase our capacity in order to reduce the backlog that has accrued during the periods of so from the first lockdown throughout to the last lockdown. So that's a funding uplift of 1.86 million, which we're using to fund 3 initiatives. I've already mentioned the cataracts and endoscopy project, where we're going to have 18-week support coming onto the island to do some weekend work. We've commissioned Medifer, which is a virtual outpatient provider, to deliver 10,000 outpatient appointments. That's across a number of our worst the areas where we've got the highest waiting lists. And then lastly, will be commissioning I'll Listen, which is also called Minds Matters, which is an on-island third sector organisation to work with the mental health service to provide some additional cognitive behavioural therapy and counselling resource, because we currently have about a 18-month waiting list for cognitive behavioural therapy. From a cancer point of view, like the UK, our cancer performance has reduced during the COVID period. There's quite a few reasons for that, shielding members of staff being one. An increase in demand following the lifting of restrictions, which we think is due to late presentations, is another. So our area of most concern is within the breast service, but you'll have seen in the media, hopefully in the last few days, that we've come to an agreement with Spire Hospital in the Wirral to provide some additional clinics. So we've purchased 80 clinic appointments for people who are waiting to see a breast surgeon, and they will undertake the whole pathway. So if a lady is diagnosed with breast cancer, they will also do the operation as well. So they'll do the whole pathway, but make sure that they are involved in our MDT. So if somebody needs oncological therapy like chemotherapy, that will be done on island. We've also got a backlog within gynecology cancer, but that is being addressed internally through some additional clinics. From a diagnostics point of view, Teresa mentioned before, but we're currently doing around between 800 and 1,000 COVID tests a day, which is all going through our pathology lab. We're actually only funded to undertake about 200 a day. So as a result, the team are working pretty much 24 hours a day to make sure that those results are processed within 24 hours, and they're doing a sterling job. However, we're hopeful that some of the changes that were agreed by Tim Wald last week around the use of lateral flow devices will take the pressure off the lab, because we're actually finding that lateral flow devices are around 97% as accurate as lab tests within certain circumstances. So that we hope will reduce the demand on the lab. And then I think finally I wanted to say is we're having reports across from a lot of the population that people are finding it difficult to access their GP, particularly for emergency slots, and that is having a knock-on effect within our emergency department and meds. So our emergency department demand is up about 40% and meds is up about 60%. So what we're doing is working with the GPs to actually institute what we call the winter pressures funding. So winter pressures is, we're not in the winter, so we're in an unusual situation where we're seeing winter levels of demand, but in the summer. And for those who've noticed in the media from the UK, their hospitals and GPs are in exactly the same position. I heard the medical director of one of the big hospitals in the northwest saying the other day that they're seeing winter levels of demand in July, and we're no different. So we've instituted the winter pressures funding, which is essentially to provide GPs with some additional funding to allow them to increase their capacity, both during the day and evenings and in weekends, so that people who are ringing up particularly for requesting emergency appointments are getting to see by their GP on the same day or the day after, rather than having to go to A&E. And that's all I wanted to say. I just wanted to check that with Andy whether the glossary was right. Okay?
Thank you, Ollie.
Yeah. And that's all I wanted to say.
Okay, well, Oliver, thank you for giving us sort of the main points of this report, but I think we need to acknowledge that the report itself still needs an awful lot more work doing on it.
Mm-hmm.
So, for example, in any one area, you tend to have one or two data points, which doesn't give you the trend. It doesn't enable you to benchmark it against comparable organisations elsewhere. So that's why we've had a sort of verbal set of highlights from it. What we should have is a report where those highlights stand out for themselves. And I know that there's already been a lot of improvement, and I know you're going to do a lot more, but I think we will need to keep on at this report until it does actually give us the information that we really want to be assured of how the organisation is performing. Teresa.
Yeah, so I might want to also ask the Chief Information Officer to also comment on this, but within the background, and we've got a presentation coming to the Executive Management Committee on Friday, there is a huge amount of work to automate this report and to get it in the format. And correct me if I'm wrong, Richard, but I think we're looking at the end of September for that to be completed with a huge programme of work which agrees the data sets for mental health, for integrated community and primary care, for hospital-based services, diagnostics. But actually that should track through, which means that we have something more of what we would have liked to have seen right at the outset, and we have that in place by the end of September.
Strange response to being asked a question.
We've lost the CIO.
Nearly choked on a boiled sword.
We thought it was a question, Richard, but
yeah. So I think, correct me if I'm wrong, Richard, but the integrated performance report that would be received by the October board would be in its new format. Is that correct?
That's correct. Essentially, the report that we see today is very much manually created, and there's a lot of manual activity to go into systems and pull that data out, because there is no automated reporting today. And as Teresa described, the work that the business intelligence team is doing under the auspices of the Health and Social Care Transformation Programme is to, first of all, create a core data set. So what are those items of data that we need to be storing in the centre? Understand what reports come out of that core data set. So, for instance, to report against the mandate, the required outcomes framework, the integrated performance report that we're seeing today, data for regulators, and other KPIs that we need in order to run the organisation. And at the end of September, we'll have done that work on the initial core data set, and we'll, for those pieces of information that are automatable, we'll be pulling those out into the core data set. And of course, that core data set will be a living data set, and we'll have very strong change control, version control around it, and it will continue to evolve over the next decades, one would hope. But certainly the subtlety here is that at the moment this is very much a hand-cranked report, which is manually done on a month-by-month basis, and we need to move that towards an automated system.
And it's fair to say also that that's something we've been monitoring at the Data and Informatics Committee, which we haven't reported on in this because there hasn't been one in this cycle, but we are monitoring the progress on that at that committee.
good. Well, we look forward to seeing that much more sophisticated report in due course. Any other questions on the IPR? Andy?
Just one, which is one of the things I know that you've mentioned several times, Chair, is at least some kind of mortality rate availability. Now, Richard kindly shared with us a crude mortality rate. I think with a little more work, we should at the very least have a mortality rate, in whether it's crude and it is manual for the timing or whatever, because it's a good early warning if something's going wrong.
Yeah.
And I think we absolutely should that almost be the first item in the report every single time.
I agree. And as soon as we have properly embedded historic clinical coding, then we should basically get one of the proprietary mortality reports, which gives us sophisticated benchmarking.
Couldn't agree more.
Because this is a real deficit in our knowledge about the quality of care at the moment. Thank you. Sure. So, well, Vanessa, I'll go that way around. Vanessa first.
Unless you wanted Sri to answer the
Are you on the
question
same
about
point?
mortality.
Just on the same point,
Mortality,
we have got a bit of crude mortality at the moment. So for the next 4 papers, you will see a bit more of crude mortality. So you'll have some indication as to where we are. Okay, fine.
Yeah,
Vanessa.
I just want, and I've got a lot of possible detailed questions, which I'm not going to ask now because we've covered some in Quality Committee. But I don't underestimate how difficult getting this right is, because we're actually looking across a whole integrated care system, not just a hospital or acute trust or a social care system. We are integrating the whole thing. So I don't think that I would want to be overly critical about it, but I think at the end of the day, but it is weird when we see things like somebody we don't know who's authored it. You know, that likewise a budgetary figure is not one I readily recognise, you know, in the narrative, and I don't necessarily know why. That seems a sort of strange thing to read in a set of board papers. So I think that from a non-exec perspective, what I really long to see is us being really clear about our visions, which we are, and having absolutely the right standards or the right things that we're looking at. Where we are now, exactly where we want to be, how we're getting there, and when we've arrived, you know, and how well we've arrived, and that's the crux of it, and that makes it sound really easy. And I'm not underestimating. I think it is quite hard. But thank you all the same.
Okay, thanks, Sarah.
Work in progress.
Absolutely, Sarah. Did you have your hand up? No,
Yep.
sorry, you didn't. I beg your pardon. Sorry, Nigel.
Yeah, thank you, Chair. I'd just like to give the board some assurance on this, because the non-executive directors had 5 presentations yesterday from the care group leaders here at the hospital, and I was very encouraged, immensely encouraged, by their understanding of the vision as to what we want from the data and where we are actually getting at the data. So, you know, sometimes when you are looking to extract information or get data, people are producing the wrong information at the wrong time. There's a real desire to produce the right information at the right time, and there's great alignment with the leadership team, which I thought was immensely encouraging.
Good. Okay, right. So now we're going to move on to the patient safety part of the agenda. 2 areas of quite significant concern. So first of all, Teresa, breast services.
Yes, thank you, Chair. So as the Director of Ops alluded to, we have had some challenges achieving the 2-week wait standard across a number of tumour sites, but breast has been particularly challenging and has been challenging for at least the last 12 months, if not the last 18 months. I think it's really important to state our commitment to delivering sustainable breast services on island. And because of that, we have already taken the steps to invest in additional workforce. So we have approved the appointment of an additional consultant breast radiologist, additional breast radiographers, and are looking to appoint a substantive breast surgeon to the island. So we absolutely want to provide clinically sustainable and financially sustainable breast services on island. But not achieving the 2-week wait compliance is not acceptable to us, and we haven't been able to put sufficient capacity in place with the workforce we have. And part of that is because of the issues with lockdown and shielding staff. And part of that is we have seen quite a significant increase in demand in that service. And one of the things which is really, really important in breast services is we must maintain that triple assessment one-stop clinic approach. Unbundling that and doing it differently is just not best practice. So we've taken the decision to outsource some of our breast services and have entered a contractual agreement with Spire Murrayfield in order for them to do our triple assessments and subsequent surgery for any ladies who need that. We've commissioned that during August and September, and that should see us return back onto trajectory. The additional workforce, a lot of that is getting put in place as we speak. So the breast radiologist post is currently out to advert, and we're interviewing for that post in early September. So this is a short-term interim solution to achieving additional capacity. We did media around this matter last week. We have worked really closely with the breast cancer charities to get their support for this, and they are incredibly supportive. And we have started offering patients who have been referred under the 2-week wait the opportunity of choice, of having their appointment across in Liverpool. As of today, we have offered choice to around 45 patients with around 10 accepting, so sort of around 20% uptake. That will really help capacity. So it is just to update the board on that development, given it had been featured in previous board reports as one of our biggest areas of risk and challenge. But I'm hoping that this additional actions will mean that we are back to 2 weeks for patients referred by mid-September.
That would be a very great improvement, certainly. Any questions on the breast report? Yes, Sally.
Just a question and a comment. I'll start with the comment. I was really pleased to see the joint working with the charity. I think that's really important, and we know that a lot of women go to the charity for a lot of support, so that was great to see that. I was just a bit disappointed by the uptake, Teresa. Was that what you were expecting, 20%, or had you hoped for higher? And are there any things that we can do to encourage more women to accept this opportunity?
I think it's early days. You know, I think it is perhaps a little bit disappointing, but we do also know we have a lot of ladies who would just prefer to stay on island, and hence why we've done it in a choice way. Yeah, so I think in my experience of offering choice previously in other roles, I think uptake usually is quite low, and people usually are okay and would prefer to wait than travel. I mean, it does allow the ladies to travel in one day. We've commissioned additional flights from Logan Air to make sure they're back at a reasonable time and they're not having to stay overnight. So, you know, we have chartered additional transport capacity in order to make sure it's not overly onerous or doesn't require an overnight stay. So they are able to go to Liverpool in the morning and come back sort of mid-afternoon following their triple assessment. But as I say, I think we just need to work through all of the ladies and continually offer choice.
And maybe encourage those who have gone to talk about their experiences.
I think that's a good idea. I think that's a good idea.
Thank you.
It is exactly the same assessment process as what we offer here.
Thank you.
Okay, shall we move on to the next area of concern, the criminal exploitation of children and vulnerable adults? Sally.
Yes, thanks, Chair. Social care have been working closely with multi-agency colleagues, including the police, in respect of increased concern relating to criminal exploitation of young people and indeed vulnerable adults on the island. A report initially, as Vanessa said, went to our Quality, Safety and Engagement Committee earlier this year and is also tabled for our private session this afternoon. The paper is tabled to go in private session this afternoon for a report that provides an overview of multi-agency evidence planning to date and seeks to cite the board on key issues in the respect of exploitation, the impact of that exploitation, and the service needs and the responses to date. The issue is a concern for all agencies involved, and raising this in brief in this public session is to offer and provide some assurance that the issue is high on everybody's agenda and that it has been fully escalated within Manx Care Board.
Thanks, Sally. And as you said, that's being taken in more detail in the private section because of the confidentiality issues there. Right, so we move on to the working culture section. I think we've got an update from Anne.
So I'll take the report read. Sorry, Anne Corkill, Director of HR. As has been highlighted, this piece of work feeds into the required outcome of creating a positive working culture. I'd stress, I hope it's evident from the report, but this isn't done in splendid isolation. This work's done with staff and management, other experts within HR. And I think it's been subject of discussion of some of our consultative committees lately, and I think it's worth recognising there's a really strong desire from our staff representatives to be involved in this. And I think perhaps that's an area where I personally need to make sure that's happening. I'm not sure we've quite got that right yet. That's all.
Thank you, Anne. Any questions? No. Okay, well, we'll continue to get routine updates on that. So I think this is the area where you know, we can achieve so much good by having a healthy working culture, which then leads on to better quality and safety and leads on to better efficiency as well. So it's the means of achieving everything else. Right, moving on to the financial section then. First of all, a verbal report on the budget update.
Yeah, thank you, Chair. We received formal notification from Treasury this week to confirm our assessment or our assumptions that our budget submissions for the financial year 22-23 will need to be submitted to Treasury by the 27th of August. So that presents quite a challenge to us as an organisation for a number of reasons. We're 3 months old or just over, and we're finding our feet and understanding exactly what we've got in our baseline and what our services look like. DHSE are still understanding and working through what they want the service to look like in 22-23. So as previously discussed with the board, in conjunction with our DHSE colleagues, we've adopted what we're calling a pragmatic approach, which is to say we just keep doing what we're doing. We're not projecting any major changes to service delivery unless DHSE has fully articulated that. So we're working closely with our DHSE colleagues to work up what that budget looks like. And we meet weekly and we're reviewing. There are a number of business cases that we're looking at the minute where we do wish to seek additional funding for additional services. So that work is on track, although it's incredibly challenging to try and pull that piece of work together in time for the 27th of August deadline. However, the board, as Nigel mentioned earlier, will be meeting in August specifically to discuss the draft budget, and I think we've got a private session this afternoon to look at some of that in more detail.
Thanks, Jackie. I can't see anybody with any questions about the budget at the moment, so do you want to move on to the month 2 report?
Yeah, so again, I shall take the month 2 management accounts as read. Just a couple of highlights. As always, we are experiencing particular continuing financial pressures, and that will continue for the rest of the year. COVID is presenting an enormous amount of not only operational pressure but financial pressure in the system. So incorporated into the figures is some spend on COVID where we haven't gotten formal Treasury funding approval yet. So until that happens, we need to show that. So until we've got that signed off, we are in the process of doing that. But for now, we have to maintain that as part of our actuals. Also, one of the things that's creating an enormous amount of pressure is the fact that the private patients unit was originally forecast to be opened during this year, and obviously that's not happened. So that represents a really huge pressure in terms of loss of income for us. And again, we have some potential plans to try and address that, to try and mitigate that, but that is limited because that unit also forms part of our outbreak or our escalation process. So we have to manage those two things. We can't have a fully operational private patients unit that is also available to be used as an overflow should the situation escalate. So I know that myself and the Director of Operations are working closely on managing that situation. Also, we have the pressures around use of locum and bank staff, and again part of that is driven by operational pressures. However, part of the SIP plan, which I'll talk about later, is trying to address that, and one of the big pieces of work that's happening is trying to take vacancies and take a concerted effort to try and fill those, not with locums or with agency or bank staff, but with substantive staff, which will help reduce that. But as I say, it continues to be a very tight situation financially.
Teresa, you go first. Yep.
Thank you, Jackie. There's probably just a couple of areas that I think the board perhaps might want to look at in a bit more detail, or perhaps ask the Finance and Performance Subcommittee. I mean, I think it is a challenge that we've clearly got an income line for private patient units, which we haven't been able to establish. But we would have had expenditure in the baseline. And do we know the netted off figure as to ultimately what not having that private patient unit would impact on us?
Yeah, so I think the net impact is about 0.8 million net.
So it's a majority.
Yeah.
Okay. And I think the other thing which, I think we are identifying lots of areas where previous business cases have been written around COVID response, but clearly in the testing and swabbing area, we are doing way in excess of what the original business case talked about. And I think a third factor, which again will be driving our agency spend, is the annual leave entitlements that people now have, having had that rolled forward from not being able to take it in previous years. Staff are now tired and wanting to take leave, and they have, of course, a much higher leave allocation for this year, which ultimately they now wish to take, but ultimately means we have to backfill often with expensive locum and bank agency. And I think, again, that will be driving some operational cost pressure.
I think it will be, just taking your last point first, it will be driving some, but we do have a mitigation for that, because some funding was secured from Treasury for that, so we release that on a monthly basis, but it may not necessarily match exactly what's being taken. And I think the other difficulty we potentially have with that is measuring it. So when somebody takes leave, it's not patently obvious that it's additional leave or whether it's regular leave. In terms of the forgive me, what was the first one, the middle one?
Just resetting the business cases around COVID expenditure.
Yeah. So yeah, we as I say, we have funding was agreed at the beginning of this financial year, for COVID swabbing and vaccinations, and we've pretty much exhausted that now. So again, we're working with the Director of Infrastructure and Operations to prepare our funding requests to make sure that that's sustained as long as we need it to be.
Okay, now I was a bit critical of some aspects of Oliver's performance report. So to be even-handed, Jackie, this is the month 2 finance report, and we're nearly at the end of month 4. Can we expect at some point to be having the previous month's finance report brought to the board, as opposed to 2 months previous?
Yes, so we're doing some work within the team to try and bring forward that reporting, because obviously ideally we would be looking at the prior month. We have some challenges around the shared services function that's provided by Treasury in terms of timing. And I think the other thing that we're trying to do, which hasn't really been done before, is to build some time into the process for active conversations with budget holders. So the numbers themselves, the actual numbers, come out relatively quickly. The work goes into discussing those numbers with individual budget holders so they understand what's happening, and getting away from simply reporting on this is what happened last month, to saying this is what happened last month, this is the position we find ourselves in, and this is what we're trying to do. So to try and shift that focus from backward looking to forward looking, and focusing more on our forecasting. And obviously those conversations take a little bit of time, and we have some work to do with some of our budget holders. Some are already there in terms of what they need to be doing, and some need a little bit more coaching. But it's absolutely an ambition of the finance team that at some point, hopefully by the end of during this financial year, that you will have more up-to-date monthly reporting.
Well, that's good to hear, because I mean, in my experience, when you run into financial difficulties, which we're not in strictly speaking at the moment, the earlier you know about them, the better.
Absolutely.
So,
absolutely.
Okay. Nigel.
Andrew, if I may, Jackie, I wonder if it would be useful if you could maybe just talk a little bit around the discussions we've been having about contingency funds, and particularly some reserves. Boards, as we know, hate surprises, and accountants love reserves, but auditors hate reserves because they can indicate that there are liabilities that can't be seen. So these contingencies, so one of the things we're trying to set within finance and performance is building in addition to our cost improvement and in addition to our undertaking savings, is some contingency reserves. So we expect the unexpected. And there are 2 particular areas really, but the one area that I'm thinking about is the expense of patients, where you can be hit by an expensive patient who needs care, and that can vary our results by anything from £500,000 to £2.5 million. But a lot of good modelling has gone on around this piece, and I just wondered if you'd like to sort of explore that with the board a little.
Thank you, Nigel. So taking on board your point around contingency, we do have a contingency within our numbers, But what I would say is that that contingency has been fully allocated against known funding pressures or requirements. So whilst it hasn't been spent yet, we have allocated it out, which is why we find ourselves in that tight position, uncomfortable position of not having free contingency at the moment. What we expect to do is when we reach the halfway point of the year, what we would normally do then is have a full review of that and see if all of those things have come to pass and if there are opportunities perhaps to release some of that and assign it elsewhere, as Nigel has said. When it comes to private high-cost patients, yes, so part of our forecast does incorporate an element of some known high-cost patients. So these are things like typically organ transplants or other such things. And as Nigel says, some of these can have enormous impacts. So we're doing some modelling to try and see if we can generate some way of funding that on an ongoing basis by anticipating and sort of feeding into a pot that builds over time that then we access when it happens, because the nature of these things is that, you know, you could have nothing for a year or two and then you could have everything happening all at once, because it's very difficult to predict. You can predict the incidence of these things relatively straightforward, but the timing of those incidents is where it causes the difficulty. So we'll have had years before where there's been one or nothing and you've been able to accommodate that. But if you get, as we're experiencing this year, we've got, I think it's about 5 or 6 that we're aware of, that then becomes difficult to accommodate and mitigate from within your baseline. So part of that drive to creating that financially sustainable modelling system and funding system is looking at how we can address that more sensibly and sustainably in the future.
And this is a significant change, Chair, because historically a business case would be made to Treasury or to our stakeholders for additional funding, and this is very much part and parcel of our ethos to seek to be good financial citizens and therefore not provide us as a board with surprises, but conversely not provide our stakeholders with surprises either, and be keeping to go back with open hands for more money.
Very important, well made point. Yeah. Okay, do you want to move on to the Act 3, the CIP?
CIP, yes, Holy Trinity. So as I mentioned earlier, we've got our cost improvement programme, and this is a huge part of delivering our financial target for this year. And we're progressing through that. So we've had the initial deep dives, we've had the main report that was submitted by MIAA, who are our consultants in that matter. And now we've begun a very intensive operationalisation and acceleration of delivery phase in that programme. So we've had some kick-off meetings with each of the areas that have been identified. So we've identified some key areas that we want to focus on. As part of our initial discussions, we identified lots of opportunities around the organisation, some of which could be done quickly, some of which were longer term, some of which required structural change. And what we tried to do in year one was, because we only had a partial year to do this, we began on day one, is we tried to identify those, what we call the low-hanging fruit cash out savings that we can deliver, not with minimal effort, but the easier targets that allows us to then build into our more difficult ones into years 2 and 3. So part of what we're doing now is that reviewing all of those opportunities, identifying those key ones that we feel are actually achievable in this year, and now we're putting governance around that and putting in some targeted operational support, which I think is a difference of approach to the SIP programs to before. Is that previously a target would be allocated, opportunities would be identified, and it would be passed out to others within the organisation to deliver, alongside their day jobs and everything else that they needed to do. And what we're trying to do with this programme is to offer some targeted operational hands-on support that allows that delivery to get going. And so, you know, there may be requirements for data gathering, or there may be some subject matter expert input that we require, or some modelling, or just, you know, general hands-on help in terms of having conversations with different partners. So we've engaged MIAA as part of their support for that, to do that, and to do that for each one of the work streams. We've had all of the initial meetings now, bar, I think we've had the non-elective care elective care one needs to happen. And that's been really, really productive, actually. I've been pleasantly surprised at how enthusiastic people have been, because we started with our list of things that we need to do and putting names against those lists of who would be responsible for delivering individual pieces of work. And we weren't short of volunteers within teams and around teams for what needed to be done. Everybody recognises that there's a lot to be done and it is a challenge. And I'm pleased to say that the conversations we've been having are very open, and we've identified, there are some challenges, and part of this is understanding if something's not achievable or is going to be a problem, we need to know. If something requires additional resource to get it going, we need to know, and therefore develop our plan. So as you'll have seen in the management accounts, we're not forecasting any of the actual cash savings to occur until the second half of the year, to allow for this, the governance and the structures around this to take place, because the idea is that this is not a one-off exercise to generate £2.7 million worth of savings in this year. It's about embedding a way of working into the organisation. It's embedding some structures that allows us as an organisation to keep this work going, because this is not for this year, it's every year. And it's totally about addressing, as I say, using our resources more efficiently. And if we deliver savings over and above our target, and we have other funds available, that money will be reinvested in other areas of the organisation. And I think that's the real driver for this. I think the other point to make about the SIP, and it's been acknowledged and realised across the organisation, is that whilst it's perceived primarily as finance driven, it's about saving money. Actually, saving money, in my view, is almost the outcome of a good SIP programme. If you're working efficiently, if you're delivering good patient quality, good outcomes, and you're working properly, you're using your resources efficiently. And if you're using your resources efficiently, then generally speaking, the money kind of follows that pattern. So it's not just about taking money out of the organisation, it's as much about putting quality into the organisation and efficiency, and using our resources wisely, and everything that we're doing is going through that filter. If taking the money out would compromise quality or safety in any way, we walk away. We're only looking at things that can be sustained, so one-off things that are not sustainable, so looking at things that can be sustained and things that promote that equality of access, promote quality and promote efficient use of resources.
And I think that last point is the one that we really want to underline, because we started off today's meeting by hearing from Heidi and others about the neurology service and the very small number of whole-time equivalents that are available to deliver that. And frankly, the only way that we can improve that is by investing more money in it. And where can we get more money from? Well, the deal here is that the first 1% of any cost reduction that we make is part of the funding assumption for the organisation. Anything over and above that can be used for reinvestment. And certainly those of us who've worked in the UK for the last 10 years would be used to achieving normally at least 2% a year in terms of cost reduction. So I think this is a fantastic opportunity not to beat people over the head with aggressive cost controls, but to actually secure money for investment in much needed areas.
Yeah, absolutely agreed, Andrew, but I think the important first step is releasing that resource in the first place.
Absolutely. Good. Katie.
Thank you, Jackie. And I'm really heartened to hear what you said, but I can also offer some assurance about the remark you made about enthusiastic take-up, because we had some presentations yesterday and SIP was mentioned, and not only was it mentioned with gusto. It was really good to hear, especially Maria from Pharmacy. Yes, yep. Maria Bell, I think.
Yep.
Absolutely on her game. Knew exactly what her job was, knew exactly what she needed to do, and he knew exactly, as you said, that it's a byproduct almost of doing things well. So I'd just like to offer that assurance, is that what we've heard from the people that we've met absolutely underlines what you said, so well done.
Thanks, Katie. Vanessa was next.
Yes, thank you. I absolutely applaud the approach, and really pleased to hear that people are getting engaged with this, and it's absolutely critical that people do get engaged with it. Again, as Andrew referred to, those of us who have been on non-execs on boards in the UK over the last few years, my mind does almost automatically goes to, when we're talking about cost improvement programmes, goes to mid-staffs. What's, are we going to go over the top? I haven't seen anything in these ideas so far But again, you refer to it as hanging fruit, so you know I will have my BDI on it, I'm afraid, you know, over the next sort of period of time. But I don't see anything that gives me that fear factor of a mid-staffs. However, on page 12, I did have, I'm afraid, a beady-eyed Ned moment in the last bullet point, and it is in relation to stoma appliances, and it was the word need to identify unresolved clinical issues. And so you may not be able to answer this now, but I'm really interested to know what unresolved clinical issues are, and I'm making a bit of a personal connection to someone I know on the island as well who's had recent bowel surgery and an unexpected stoma that wasn't meant to happen as part of his surgery. So so I just would really like to understand that better. And
Yeah,
I'm so sorry, I do have these beady-eyed moments, and it can be very annoying, but there you are.
That's quite all right, Vanessa. I can actually answer that one for you. And it flows through everything that we're doing, whether it involves switching biosimilars or moving the type of drugs that people are on, or adjusting the kind of procedures that they're doing, or as you say, the sort of products that they use, anything to do with prescribing. Where it begins is we start with the patient and we understand what's most appropriate for the patient. And that's where that's coming from, is that there's an expectation that when you start doing that review, it won't be simply from the centre saying you can't have this anymore, and it's not available to everybody. It starts with the patient, and if the patient requires it, then the patient has it. However, if the patient doesn't require it, then the patient doesn't need to have it. Rather than it simply the finance director saying, no, take that off the list, it's not allowed anymore.
Well, thanks, Jackie, for that. I think also it's a clinical issue, so probably out of this meeting, maybe have a conversation with Sri about it. So is that interesting?
Thank you. I think Andy was next then. Yep.
Just a comment and an observation about the report overall. So it looks like around about a third of the overall cost savings are targeted towards pharmacy. But in that, there's a requirement to invest in order to release that fund, because obviously there's some cost involved in that. And I think if you don't invest first, you can't release, and that's quite tricky considering our financial position. And when I look at the savings in pharmacy, there are two immediate issues that strike me. So the first one is under the primary care medicines. You've got a whole bunch of things which are prescribed by GPs particularly, and they might be in support of people who really are lacking their own personal resources. And I think that they're going to be very difficult. There's going to be quite a bit of resistance to some of these changes, and sometimes with very good reason, I think. So I think we probably have to be a bit cautious about how much is savable in that particular section. In the secondary care medicines, there are a couple that strike me particularly. Sugamadex, which is used recovery post-op. I think I'm not entirely convinced you should be making an anaesthetist necessarily think twice about whether or not he uses that, because if he feels it should be used, it should be used. The cost reduction is tiny. To add that extra leg in for such a tiny cost reduction, I think is probably futile. And finally, capsaicin patches, which, as I understand it, are largely the pain control, and I think what they're used for particularly is for orthopaedic pain. And if we can manage to catch up on orthopaedic operations, hopefully some of those will automatically remove themselves in any case. So I think they kind of don't belong here, they're in the background. And so I think you're probably already restricting this list quite a lot. And so I think that's a slight degree of maybe over-egging in this. But invest first, release, and just see where we get to. But I'd be very cautious about restricting medics' choice in terms of what is available to them from a list we already have.
Okay, so there's two answers to that. The first is that we've tried wherever possible to be conservative with our estimates. So we've taken sort of what a benchmark would be in the UK in terms of achievement of percentage uptake or percentage switch, and tried to row that back a little bit. I think when it comes to, we had a specific conversation, because I know you asked me this question already
I
about
did.
Sugamedics.
Sorry.
So I challenged that back to the SIP team and to the pharmacists in question, and they said that when it comes to this sort of stuff, it's not necessarily, as I say, saying you can't have it anymore. It's more about putting in place clear guidelines and policies about when it's appropriate to use what. So it's not saying it's not there. It's saying, actually, in these instances, this is the more appropriate avenue. And the feeling amongst the team there was that that is an open door. It's a very, very easy thing to do. And whilst it looks like a small saving now, it's actually something that, you know, you'd be silly not to try and target that one, that there wouldn't be a lot of resistance or potential negative blowback from something like that. Whereas absolutely right, some of these other areas do have the potential to be controversial and difficult. And it's worth noting that with a number of these areas, they do require the support of the DHSC, and the DHSC needs to put in place and make those decisions about whether they're happy to support that movement. And until we have that from that assurance from DHSC, we wouldn't progress these. But DHSC are fully on board with everything that we've got in here.
Okay, thank you very much for the clarification.
No problem.
Okay, now Sri wanted to go now. I don't know if you were picking up those two particular drug issues, Sri.
I did indeed. I was just going to say, the first thing I was going to say about is the cost improvement programs in pharmacy. I wish I could kind of rename that again. That probably should be under certain different heading, which is called the medicines optimization.
Yeah.
Actually, it's got nothing to do with cost improvement. It is about giving the right care to the right patients. It happens that it will give us some cost savings as well. But it is actually absolutely, it's underpinned just by quality. It's got nothing to do with cost. It just happens that it's the money as well. And because, as you know, in the process of releasing the drugs, it grows from being, the pharmaceuticals spend a lot of money for getting, and then it becomes generic. When you get generic, it gets cheaper. And this is all that kind of, it goes into the pathway of that. So it's got absolutely nothing to do with it. So I think that's one thing should answer, give you some confidence as to medicines optimization has got nothing to do, and we definitely don't look at the cost there at all. The second bit is, I was going to speak to you. I think we realized that our cost improvement program is not as mature as we could have been. We know that we are still going into most of transactional, non-recurring, high-income cost-saving things, but I think we realize that for a long-term financial sustainability, we should have looking at more deliverable plans and financial kind of long-term waste reduction plans. Those things are the key issues here at the moment. But in general, I think that's all. I just want to make a comment of it, saying that there are lots of things that are underpinned by good clinical engagement as well.
Absolutely.
Thanks, Troy.
And if I could just address your point about making investments to release savings, you'll see in the report that actually we've got our gross savings and we've allocated an amount for that exact reason, is that we recognise that some things will require an investment, and part of the investment of the time from MIAA is part of that. It's trying to get that out. You can't always just stop doing things. Sometimes you have to make an investment to make a change. So we've allowed for that in the programme.
Okay. The final part of that also is obviously pharmacy, for instance. That's going to involve an awful lot of effort by the pharmacy team and the medical optimisations team, as such, if you like. So one way or another, there's a lot of internal investment as well as paying the external people.
Yeah, exactly. So we've that full 300,000 that's in there is not entirely for MIA. It's for all sorts of things, wherever we need it.
Thanks, Jackie.
Right, I think we can move on from the finance section now. Thank you. Now, as we saw at the start of the meeting, there were no notifications of any other business. So we'll now move on to questions from the public. We'll take, first of all, the ones that we've received in advance. So, John, if you wouldn't mind just reading out. First of all, we've got one from Daniel Feldman from Pfizer.
It's a NICE published new guidance on atrial fibrillation NG196 on the 27th of April 2021, which includes the following recommendation. For people already established and stable on the vitamin K antagonist, the committee agreed that the benefits of changing to a direct-acting anticoagulant need to be discussed. Therefore, the risks and benefits of changing medication, person's time in therapeutic range and the person's preferences should be explored at their next routine appointment. So along from there, Mr. Feldman has two questions. Does Manx Care have a general process to ensure that applicable NICE guidance is implemented? And the second part, can you give an assurance that the above recommendation will be carried out?
This is over to you, Sri.
Yeah, a couple of things I was going to say. Since that question has come in, we've actually engaged with all clinicians. It happens to be that I'm a stroke consultant as well. This NICE guidance pertains to that aspect of the treatment. So we had a broad engagement with both the primary care GPs as well as the secondary care. We had a meeting, discussed about the impact of the new NICE guidance on the care delivery on the island itself. I'm glad to report that whether NICE says or not, we are already actually quite way ahead of that. Giving the patients are not shortchanged for the way of what they want the treatment. As to the specific question of which drug should be used, unfortunately, I can't answer this in this public forum because that question comes from somebody who represents a particular drug as such, so I can't do that. But otherwise, other treatments such as tools to risk manage, there is something we are developing within the GP clinical tools, how we manage the risk bleeding, and also about the surgical options that we use for atrial fibrillation. So that is all under what the patients here in Isle of Man already get it. So this is NICE guidance only kind of underpins the care that we already provide rather than extra care that we need to actually provide. So we're quite happy with that.
Okay, thank you, Sri. So now we have two questions from Simon Mann. Can we do them one at a time?
Yeah, sure.
Chair, are the questioners in the audience? Do we know?
Well, we do know that Mr. Mann is in the audience.
Right, okay. I'm just trying to identify who was asking the questions.
Okay, so I noticed that the Manx Care Board does have some committees, but I cannot see a committee for property and project development. Given that it can take sometimes many years for consultation, planning, procurement, construction and commissioning all future projects should already be in committee discussion and move into consultation. There is no apparent sign of this and valuable time is being wasted. I would like to see this position subject to question at a forthcoming meeting. I fully appreciate that funding is not there, but the strategic project assessment is not there either. I also note that there has apparently been no strategic evaluation over property ownership of the entire Manx Care estate, particularly where existing trusts, leases and freeholds are concerned. This is crucial to any future development.
So we're passing this one to Barbara, who's our expert here.
There is a review by the whole of government, by Ernst & Young, reviewing all of property throughout government and the value of that property. That is ongoing at the moment, so I don't have a conclusion of that at this moment in time. With regard to the strategic direction and the future developments, they are already in train as they were within the department, and all of the developments are in the Pink Book. They're all with a planned capital investment for the future. So various properties, as is ongoing at the moment with regard to the rebuild of Rietna Bay, which is at Summerhill View. Those sorts of things are all detailed within the Pink Book. So all properties remain the property of the Department of Health and Social Care.
But we did have to go through a thorough list
yeah.
of the leases, freeholds and assets when Manx Care was created, so that we were clear what they all were and where they were up to.
Yeah.
So those were scrutinised at that time. Feel free to follow up to that if you wish.
Sorry,
Oh, so we just want to give you a microphone, otherwise we're not going to record what you say. Whoops.
Chair, in effect they've left this new organisation with a complete inability to progress. If you can't even start to plan what you want to do with one of your buildings at this stage, you've already lost 4 months. And I'm sorry, but this is going to have to go back to the department to hear that the department are still clutching at the assets, and they put in place this multi-million-pound organisation with they're not only not giving you enough money to do the job, they're not even giving you the ability to start planning to do the job. The situation on this island, Mr. Chairman, is absolutely dire. This lady here has just given one example of bad treatment. When this island gets its treatment of patients bad, it's not just a little bit bad, it's very bad, and that case can be multiplied hundreds of times across this island. I'm sorry, but the honeymoon period for Manx Care is well and truly over. When I recently said we need 250 million, I think it's an underestimate. This is a wake-up call to everybody here. There's a massive task that has to be done, and I'm sorry, but to find out that that the department is clinging both to the budget, to the buildings. Well, they just basically created Manx Care as a football to save them having to answer the questions.
Well, I understand the points that you're raising, and we very much raised the same points ourselves in the creation of Manx Care. And the answer is not that Manx Care is completely helpless in relation to property. It means that it has to go through a few hoops in order to get anything done in property. So we have got the ability to create new investments, we have got the ability to buy and sell land, but we can't do it ourselves. We have to go through Treasury and the DHSC. And you know, your analysis of the financial position, I'd be very pleased to have an extra £250 million, because as you've just heard, we're basically trying to save money internally in order to be able to fund the service developments that we need. But then the Isle of Man government will say that they've got a duty to balance their books, they've got a duty to the taxpayer to, and you know, it's all about managing that balance between all the parties.
Mr. Chairman, just if I could briefly respond. Just in an isolated case as far as the north of the island is concerned, right at this moment we have this amazing array of directors and a massive organisation. There's not a single thing that this organisation can do at the moment to rectify the situation where when you ring up a doctor's surgery in the morning to seek an appointment and you're told that all 4 doctors on that day are not available even to take a telephone call until late in the day. There's not a single thing that anybody in this room can positively do to change that situation. That doctor's surgery has hardly changed in 30 years.
Okay, can we take that as a separate issue about access to GPs? And I'm not sure that there's anybody in the room here that's capable of answering this, is there?
It's a pretty general situation across the whole island at the moment.
That's something that we can't answer to you immediately, the specifics, but we will look into that and see how frequently that happens and see what answers are available. Can we take your second written question? I'm just conscious of giving everybody a chance.
I'm sorry, I also don't want to take the time.
No, absolutely. No, absolutely. Well, if you share the microphone around or give it back to the gentleman there. But the second question?
Yeah, at the end of the month, Manx Care will have cost the taxpayer an additional £1 million in extra administration since it came into being. Would you please ensure that at the July meeting there is a clear summary of what has been delivered and improvements for that money? Mrs Cope and Mr Foster indicated to me that they have not yet spent that money, but the monthly cost of Manx Care breaks down to £250,000 per month for the first year, so possibly an up-to-date financial statement on Manx Care would be helpful for the meeting.
Okay, Jackie?
Yes, so I'm assuming that the funding you're referring to is the transformation funding that was to establish Manx Care, and that was about £1 million. But I would say that as Teresa and Andrew have already said, we haven't actually spent as much of that yet because we haven't filled all of those posts. So I think we're at about 1/3 of that for now.
So what's been delivered for the money?
Well, I think, Frank... Yeah, well, I think that's what this whole board meeting has been about, actually. You know, you've had reports on quality, on performance, on finance, which are, you know, there's no sort of one-sentence answer to your question. It is that huge panoply of things that's happening. You've still got 2 more questions on here, so let's let you have your share.
A colossal sum of money, £1 million even still.
Yep, sure. So, go on.
Who has actually visited Ramsey Group Practice and Ramsey Cottage Hospital in the last 4 months?
I'm happy to take that, and I think probably executive colleagues would also want to comment. But you know, as we have alluded to throughout the board, the visibility across all of our sites is really important. I certainly have at least a day a week up in Ramsey. I visited the practice a couple of times. I meet regularly with the GPs in the practice, and tend to have a day a week working from Ramsey Cottage Hospital. I do think that's pretty typical for a lot of the executives who also base themselves up at Ramsey periodically. Barbara's sort of nodding. I know Shrewsbury and Oliver. I know Sally does too, and Richard. So, yeah, I would suggest we are visible across all of our services, including Ramsey.
Could I offer a non-exec perspective
Yep.
on this? Yeah. As it happened, yesterday when some of my colleagues were having other meetings, I actually did go and have a look and took a photograph of the new signage outside Ramsey Cottage Hospital, and I'm sort of familiar with it from days gone by. But what's been really difficult in the inception of Manx Care is COVID restrictions, because certainly it would be my style, and I think the style of other non-execs, to sometimes be much more visible than we've been able to be, and have our security lanyards, and to be able to wander in and out of various care settings and places, not with a view to going and looking and seeing what people are ever doing wrong, but to actually applaud what they're doing right and look for what they're doing right, listen to people, listen to what their own experiences as members of staff. And I just really, really do hope that in due course, when we can have greater access and greater visibility, that we will be, as non-execs, be able to do just that. And the chances are that we'll raise the same questions, the same challenges, and be seeking the same assurances that you as a questioner has done. So, but thank you for the questions.
And then the final question is a similar one, but about visiting Nobles Hospital and its various parts. And I guess the answer will be much the same, wouldn't it?
Yes, and I think I've tried to certainly visit all of the teams. I've been around all of the service areas and got out into the community teams as well. I think it's been really important. What Manx Care heard when we were establishing was that we also can't afford to be Nobles centric. So whilst the sort of headquarters of the executive team is in Nobles Hospital, it is really important we are visible across all sites. And we've talked about this as an executive about, how Sally's team come into the hospital as a Murray House based team, how we are seen in Murray House from a health perspective. So it's something we are very cognizant of and keen to ensure that we have high visibility across all Manx Care sites.
And from the non-executive point of view, yesterday was the first time that the non-island based non-executives have been here, and they would have loved to have had a comprehensive tour of Nobles, but they had at least a sort of an initial tour where they were able to see the main parts of it and at least one of the clinical areas. But it's, as was said, we are quite hampered by COVID restrictions at the moment as to where we can go, but we would certainly like to do a lot more.
Just very briefly, would it be possible to organise all your executives, non-executives, executive directors to actually go on a fact-finding trip around the island, to go to all these places, to actually see them firsthand? Because when you talk about them in a meeting, when you've seen it firsthand, it's an entirely different picture.
Yep. I mean, the answer is yes. That's exactly what we want to do. We want to go around all of the premises as soon as we can, and indeed some of us have done part of that already. So I'm just going to move on to the last written question that we've got.
Yeah, so there's 4 parts to this question. So Oliver Radford's been circulated as the operations director already, so and I think they flow together, the questions. So I'll read all 4 parts together and then Oliver can go through them. So it was a question that came in this week from a Manx Care patient. Why has Ward 12 been taken over for acutely unwell admissions? Are there more patients with life-threatening conditions than those requiring urgent surgery? Why are there not areas allocated to carry out surgery on patients in constant pain and in need of urgent surgery? And why are urgent operations not allowed on a reduced scale to help the backlog? Just as a brief background, this patient had been waiting for a hip operation.
So, unfortunately, we've managed to keep the elective orthopaedic programme going from April, just after we came out of the last lockdown, and we didn't have any cancellations up until a couple of weekends ago, when unfortunately, due to the level of medical admissions that we were experiencing, we had to what we call outlie medical patients, so patients that were coming through the front door through the emergency department. We had an excess of those, so we basically had to admit medical patients into Ward 12, which is the elective orthopaedic ward. Because elective orthopaedics are very sensitive to hospital-acquired infections, so if somebody happens to get an infection within a hip or a knee replacement, that is a very serious issue that can require further surgery and even amputations in some cases. So we're very careful about how we use Ward 12. Essentially, if we put medical patients on there, we have to cancel the elective orthopaedic programme almost entirely for that week to prevent any cross-infection issues. So unfortunately, because we had to admit medical patients onto Ward 12, we had to lose the elective orthopaedic programme for that week. And unfortunately, because of the ongoing COVID issues and the fact that we've had to reconfigure our inpatient wards to create COVID and non-COVID wards, unfortunately we've had to keep Ward 12 as a medical ward for the time being, which has meant that we've essentially lost 3 weeks of the elective orthopaedic programme. So anyone who has had a hip or knee replacement booked since a couple of weeks ago have unfortunately had their operation cancelled. We've got 100, so we have within the hospital 79 allocated beds for medical patients, but we currently have 125 patients that are requiring medical care, which is obviously in excess of what we had in terms of capacity. So that clearly does have an impact on our ability to admit elective patients, so patients who aren't requiring surgery in an emergency but are able to be invited into hospital to receive their operation in a more of a planned way. Clearly our demand from a non-elective point of view, so from an emergency point of view, always has to take priority over other cases coming in, and we have some other compounding factors that are within that we're facing at the moment. For example, the closure of the Corrin home, for example, has increased the or has reduced the number of residential care beds available to us. So we have less ability to discharge patients into residential care because we've had to accommodate those Corrin home patients. I'm glad to say that we do have some light at the end of the tunnel from that point of view, because the new Silverdale nursing home will be opening in August. So that will provide us with some additional nursing home capacity, which will definitely help our discharges. And we're also working hard to try and reduce the number of delayed discharges that we have, because we have a number of delayed discharges, not just because, particularly at the moment, because care homes, residential homes and private domiciliary care agencies are operating on significantly reduced staffing because of the COVID situation, and increasing number of people that have got tested positive for COVID, but also more on a long-term basis in terms of looking at our legislation around discharges. In terms of the last question, why are urgent operations not allowed on a reduced scale? We always have to prioritise, as I say, the patients that are requiring urgent treatment, whether that's urgent surgical treatment or urgent medical treatment. And you know, it's an unfortunate symptom of having to balance both emergencies and planned operations in a single hospital, that when you do have an excess of unplanned admissions, that often the elective surgery element has to reduce, so we do get unplanned cancellations from time to time.
Thank you, Oliver. So that's all the questions that we were sent in advance, so it's now open to any members of the public who wants to raise any other questions. Nobody else? No? Okay. You have the floor again. Do you want the microphone again? I say it's not for amplification, it's just for the record.
It's actually only just an observation. I've come in here for the first time. It's a new organisation. You've got no legal officer, and you've got no legal issues committee. You've talked about mental health and all the raft of new legislation. You've got contracts that will run through virtually everything that will all need to be reviewed. You really do need to have a legal committee that all these issues can be put out to. And then if they need to take specific legal advice, perhaps from the Attorney General's office or wherever else they're getting advice from at the moment, you're going to save yourself a fortune in legal fees if you have such a committee. And that's only just an observation on that point. And the other one is...
Do you mind if I answer that point?
Let's let Mr. Mann finish completely, and then we'll...
And the other point is that we've heard discussions about the reliance on the hospitals in Liverpool, and in fact getting their healthcare models and so on within the body of locals. I've been away for treatment to Liverpool. If you listen to the Liverpool taxi drivers when they're picking all the patients up, they'll tell you that the patients in Liverpool are looking to the fact that the waiting lists in Liverpool are being made longer by the fact that every day large numbers of patients are being picked up from Liverpool Airport and taken to the hospitals. And it's not going to be long before the pressure on waiting lists in Liverpool becomes a difficulty for the Isle of Man. And I would flag it up just now because it is going to happen.
Okay, thank you for both of those. Do you want to take the legal one, John, then?
Shall I take that microphone?
Yeah, well, we do have a risk and liability committee, which is, because of the nature of the items that are discussed, it's a committee which we have representatives from Manx and from occasionally the Attorney General's chamber, so we do have a risk and liabilities committee that is established and meets normally on a 2-weekly basis to consider those kind of matters. Yeah.
And we do have a service agreement with the Attorney General's office for any legal advice, and we're sort of required to use them. It's one of those. Do you want to take the other points about Liverpool patients?
Yeah, thank you, Chair. I think it's probably important to say that other than when we hit some very specific capacity pressures, and I would point to the breast paper as sort of the example, we wouldn't ordinarily send patients to Liverpool for treatment if we can deliver their care on island. So, so those patients who we send, there is a process in place, and they go to Liverpool because the care they require can only be delivered in Liverpool, and this is around tertiary and specialist care, and we closely monitor that. They are part of our network, and we do need to have good relationships and clinically interface with all of those trusts in the Northwest who provide us with that specialist input, who contribute towards our workforce, and ultimately we spend around £20 million worth of Manx Care's budget with the Northwest, so we are contributing to their overall economy. You know, Liverpool and the Northwest, just like every other area of the country has been in the UK, has been impacted by COVID, and as a result there is a national strategy across the UK to purchase capacity from the independent sector in order to manage the waiting lists. I do think it is really important we align with that piece of work, because we are equally trying to do the same. We are trying to clinically prioritise our cases, ensure our clinically prioritised patients get the right care, and ultimately we're all trying to reduce our waiting list by using the resourcing we have as efficiently as possible. So it is to provide the assurance that we do monitor very carefully the patients who we are sending to Liverpool, and it is on clinical grounds that they go for their care and treatment there, not just because capacity issues. As I say, breast is the very clear exception to that, and that's very time limited.
Right, so that concludes that item for this particular meeting. The last item on the agenda is feedback on the meeting effectiveness and any new risks and assurances. I'm not going to spend a long time on this. This is our first attempt to have a public meeting, as I said, right at the start in somewhat unusual circumstances because of COVID. We will be reflecting on what could have gone better at this meeting, any areas that could be improved. I hope that the next time we have a meeting we won't have the same restrictions on us, and we would welcome any ideas from members of the public as to how, from your point of view, this meeting could have been better conducted. Please, go on.
Just one thing, I found it quite difficult to hear just the audio volume of some of the different speakers. It'd be kind if you could basically speak up, or maybe we get the amplification so people can hear. That was all.
Thank you. Thank you.
Thank you otherwise for having us.
Excellent point. It's funny that we've got all these microphones and we haven't actually got a speaker, have we? Anything else from members of the public just before we bring it to a close?
Just grateful to you for accommodating.
No, it's a pleasure. That's what we want to do.
To those who haven't come to the island before, welcome. A warm welcome to you.
Thank you.
Thank you. Okay, so at that kind note, I'll declare the meeting closed. Thanks, everybody.